Can someone guide?
Hello, please start.
Okay, fine. I can see here live video kind.
Yes.
Live. Okay.
On behalf of IEP technical team, I would like to welcome all participants and our today's chief guest. Welcome to all. And also welcome to our today's speaker, Dr. Vipin sir. Welcome you, sir. Before hand over this webinar to our today's moderator.
Hello, please start.
Okay, fine. I can see here live video kind.
Yes, ma'am. Go ahead.
Hello, you are at mute.
Yes. Before hand over this webinar to our today's moderator, Dr. Srijinath sir, I request to all participants, please subscribe our own IAP YouTube channel. Thank you. Thank you, sir.
Thank you.
Shall I continue?
Yes,
sir. Yes, sir.
Good morning. Welcome to all. In this Corona period, I hope all are safe. Here, I would like to, first of all, I would like to thank IEP team for creating such a wonderful platform which can be reachable to all over the world. And here we'll be discussing a topic on neuroplasticity. And here we have our great treasurer, Ruchi Vashini ma'am, as a, I'm not saying as a chief guest, she always with us only and always inspiring us only. I'm welcoming Ruchi ma'am for this one. And here with we are conducting our second webinar on behalf of IEP Kerala. This second one is being hosted with the involvement of IEP Kannur branch. And I welcome Biju of convener of IEP Kannur along with the Secretary Suresh and Treasurer Rias. And here with us IEP General Secretary Jim Gopalakrishnan is there. IEP Kerala Treasurer Baiju Vijaykumar is there. And our resource person Vipin also is here. Hope he will have a wonderful session with us. And I will invite Ruchi ma'am to have a start of this webinar. Please, ma'am.
Thank you, Srijit sir. Thank you, IEP Kerala chapter, to invite me. It's a pleasure. It's an honor. And thank you, Vipin sir. Basically, the idea of having webinars on this platform is to connect the entire country in one platform. It is basically like Kerala is the distant most state of India. And here it's not only Kerala watching you, sir, it is the entire country watching you. So our idea was to connect and collaborate all the esteemed resource persons from the distant part of the country. My throat is not good today, but from the distant part of the country to the, like as far as Jammu Kashmir, to the western, to the northeastern states. And this is what we are trying to do because somewhere this connectivity was missing. And this COVID-19 period, though it is a very emotional, psychological, financial setback for most of us, these 3 months. And but still, I would like to say congratulations to Kerala, the God's own country, that you all have handled it like New Zealand for all of us. And basically the program, the way you have dealt with this situation, your health minister has handled it well, the citizens, the state people, they have handled it. So we are following you. I hope in Delhi we get a bit of the sense more. Otherwise, I would like to thank all the participants to participate here. IEP Kerala, this is second webinar. IEP is the association, the parent association from 1955. We are representing the largest number of physiotherapists. And I would request, one request as a treasurer of IEP, I would like to put up that please, first and foremost thing is our profession. Please love the profession because we are here because of the profession. Second thing is association. Association is good or bad because of us. So please trust the newly elected team of your state of the country. We all have the same passion, the same love for the profession. We want all of us to grow. We want us to be recognized as a very strong profession, as the backbone of the medical profession, as the like we are very important, very essential, and we want government as well as our physios to recognize and appreciate all the efforts put up by the state chapters, put up by the central IEP team. So I would like to congratulate Srijit sir, Jim sir, the other IEP members sitting here for this wonderful webinar organizing the team. And thank you to the esteemed resource person. Thank you for inviting me. Thank you for having me here. And let us have a great learning experience today.
Thank you, ma'am.
Aloki ma'am. Thank you, Indian Technical Team, IEP India.
Thank you, Ruchi ma'am, for trust.
And over to Jim Gopalakrishnan, our State General Secretary, for a few words.
Thank you. A very good morning to you all. Respected President, Dr. Sridhar Namburi, State Treasurer, Dr. Ruji Vashni ma'am, our
National
Treasurer.
Can be the State Treasurer also, sir.
Okay. Our resource person, Dr. Bhupin, and the convener, Dr. Biju from Kannur, and all the team from Kannur, State Treasurer, Baiju, and Vice President, Dr. Vinod Raj, and all office bearers and panelists and dear members. It's an immense pleasure for me for this first webinar that has been started today. It is a great initiative of our parental body IEP Central Committee. I always, we all thank you for the right moment on the right time. This is the lockdown period, and we all are lacking of so many things, but support and all the things given from and the unified movement which has been come up from our IEP is much more appreciable. I want all of us to stay together and work for the moment. And this is a crucial time we are facing up. And of course, the learning is much more important for us. Like you learn, and you showcase yourself as a physiotherapy professional to the entire world. And we are keeping on doing a social work. Comparing to other professionals, we are much more giving a social work to the society as a professional. We should be proud to be a physiotherapist. And this moment, I would like to thank each and everyone who have been working to make this event happen today. And all of you, all the best for a successful learning. Thank you. Thank you very much.
Over to Baiju Vijay Kumar, our State Treasurer, for 1 minute to talk. Over to Baiju.
Good morning, one and all present in the meeting. I am Baiju Vijay Kumar, Treasurer, IEP Kerala chapter. I welcome all of you to attend our first webinar. Our second webinar. We are planning for a series of webinars. And today we have a resource person, Dr. Vipinnath, who is currently working as a professor and HOD of Neurophysiotherapy Department, Alvas College, Mudabadri, Dakshina Karnataka. He is an eminent personality to deliver a topic about neuroplasticity. I welcome Dr. Vipinnath to this webinar.
Thank you.
And I welcome all of you, our state and national office bearers, to this webinar. Thank you.
Over to Biju, convener of Kannur IEP, to have an introduction to our resource person to all of us. Over to Biju.
Biju, unmute.
Okay. Sorry. Is it okay?
Yeah. Audible.
Okay. Good morning to all. This is a happiest moment in our IEP. That is the second webinar we are going to conduct today. And now, first, I would like to welcome all to our webinar, especially our Ruji Varshni Madam as a state central treasurer, and our state president, Dr. Sri Namburi sir, and Dr. Jim Gopaleshan, and our resource person Vipinnath, and Dr. Baiju Jayagumar, and we are expecting Dr. Vinod Das also. So, as you know, this is a tough situation in our country, that we are facing a drastic coronavirus. So even though the learning is not going to stop, we should learn all the aspects of physiotherapy. That is, today we are in webinar. So I am entering to my duty, that is introducing my friend and our executive member of Kannur IEP, Dr. Vipinnath. And as you know, he's working as an associate professor and head of Neurophysiotherapy department of Alvas College of Physiotherapy, Udabadri, Dakshina Karnataka. And he is graduated from Mother Teresa Institute of Health Science, Pondicherry, in 2006. And then he was he entered to the postgraduate stream and in neurology and psychosomatic disorders from the Oxford College of Physiotherapy, Bangalore, in 2008, and holds a postgraduate diploma in manual therapy. Even though he is a neurospecialist, he was showing immense interest in the manual therapy procedures, and because we were together within 1 or 2 seminars, and we had a good time that day. You might have remembering these things. So, and he was post diploma in manual therapy from Vinayak Medical Mission University Salem, 2015, and he is also a Mulligan practitioner since 2014, and he is having total 12 years of clinical experiences, and presently he is guiding many of graduate and postgraduate students for the researchers. And his area of interest is, as he is today selected, the neuroscience and neuroscience of pain and neuroplasticity and stroke rehabilitation. So by these words, I am happy to introduce in front of you Dr. Vipinnath, MPT Neuro, for conducting sessions today. Thank you.
Thank you, sir.
Yes, Vipinnath, we have evidence from 1890 regarding the neuroplasticity, and the current situation, even for Alzheimer's disease, like a neurological problem, and after brain injury and neurological injury, we can utilize the ability of the brain, neuroplastic effectivity of the nervous system for a wonderful rehabilitation. Over to you. Have a wonderful session. Okay, thank you.
Thank you. Shall we start?
During session, if any participants have any doubts, you can just write down in a chat box. After once the session is complete, we will discuss.
Okay. Okay.
Hope everyone is able to see my screen.
Yes, sir.
Okay.
Sir, please start slideshow.
Yeah. Able to see?
Yes, sir. Thank you, sir.
Okay. Thank you. So, Biju sir has already given an introduction about me. So, a little bit of about where I am presently working. So, I am happy to share that our Alvas College of Physiotherapy, this year we are celebrating completing 25 years of service. Okay. And about our institution, Alvas College of Physiotherapy is the unit of Alvas Education Foundation, and it is affiliated to Rajiv Gandhi University of Health Science, Bangalore, and we are recognized by the Indian Association of Physiotherapists. Okay, so we'll start this session. Okay, so when we say the word plastic, okay, what usually comes to our mind is the plastic bottle, okay, the plastic brush, or like whatever plastic items we see in day-to-day life. Okay, but if you see the meaning of plastic, actually it means that it's a material which can be easily shaped or molded. Okay, it has an origin from Greek word plastos. So when I mean the word plasticity, that plastic should go away from your mind, and this kind of picture should come in your mind. That is something which can be easily molded. Okay. And and the neural plasticity or the neuroplasticity. That means that it's the ability of the central nervous system to change and adapt in response to environmental cues, experience, behavior, injury, or disease. So, what do we mean by this? Okay, it's nothing but our nervous system is continuously keep on changing. Okay, so suppose we go into some environment. For example, we need to walk on a slippery floor. Okay, see, our walking pattern changes. Okay, according to that, so we start taking our steps very cautiously in order to see to that we don't fall down. Okay, so this is a response, okay, which is created by the brain according to this environment. So why we do that? Because we might have a past experience of falling down. So in order to avoid the fall, we are doing that. And we have like a lot of behavior changes happening in the body. That is because of the neural plasticity. Or like the changes we see, suppose a patient with stroke, okay, the changes we see in the body, okay, the synergy or the circumdactory gait, all those things are the result of the neuroplastic changes happening in the brain. Or we take an example of Parkinson's disease or multiple sclerosis. Whatever the changes we see, that is the result of the neuroplasticity. So a little bit of history about the neuroplasticity. Hope you all will be knowing the person Broca, or you might have known the area, Broca's area for speech and all. So that was in 19th century that a scientist named Pierre Paul Broca, he localized different areas in the body. That is according to the somatosensory cortex and also in the motor cortex. Okay, so this, okay, you can see in this picture I have put, we have different parts of the body represented within the brain. Okay, so after this focalization or localization of different areas in the body, like we were thinking, or the previous people, they were thinking that it's fixed. Okay, everything is fixed and there is no changes once the person or the adult brain gets mature. Okay, so this thought was continuous, and I think the first records what we can see was William James. Okay, he was a American philosopher as well as psychologist who mentioned the word plasticity. Okay, but he himself, people were, more skeptical or very doubtful about his viewpoint. Okay, and it continued till the 1960s. Okay, and this had a very negative impact in the field of neurorehabilitation because we were more concentrating on the compensatory approaches in the for the neurological patient. The belief that the brain new functions can be trained was not acceptable for many people. And in the year 1967, a person called Dr. Paul Bach-Irita, he published a research article about sensory plasticity. So even for this article, he was telling that many reputed journals rejected this idea, his idea of plasticity, and only finally one journal which has published it. Okay, his experience we can see is his father met with a stroke. Okay, that was a very massive stroke according to him, and his brother, who was a psychiatrist. Okay, they both rehabilitated him, and he was able to go back to work. Their father was able to go back to work as a full-time working, and he was even going for hiking. But what happened is during hiking somewhere around 9,000 feet above. Okay, the person again met with a stroke and he died. But that recovery from a stroke, he was able to perform all his activities. So what happened after this person's father died? They did an autopsy and found out that whatever the brain damage the stroke has caused, that was still there. Okay, even with that much of brain tissue damage, this person was able to do his daily activities. He was able to go back to work and even for hiking. So this made Dr. Paul Bach-Irita do researches on the brain functions. Okay, and that's how like everybody started accepting the plasticity, neuroplasticity, the idea of neuroplasticity, and a lot of researches are coming up now. So how do this neuroplasticity occur? Okay, so neuroplasticity results from a change in the function within a particular neural substrate in the CNS through alterations in synaptic strength. That is, the synaptic strength may increase or decrease. Then neuronal excitability. We all know that the neurons have excitability, okay, which can increase or decrease. Then it can be either formation of new nerve cells, that is the neurogenesis, and death of cells. All these things result in like neuroplasticity. So we'll go to a bit of details about the types of neuroplasticity. These, I'm not going to a bit of much of biochemistry aspects. What you can do is like let us have an idea about this almost 10 types of neuroplasticity are there. So this will always like change our thinking, okay, so that we can motivate our patients for functional recovery. So the first one is synaptic plasticity. So you can see here I've put 3 pictures. The first one above, you can see there is axon terminal, and we have the synaptic cleft, and you can see some neurotransmitters over there. And we have the postsynaptic membrane, the dendrite of another neuron. You can see here the action potential reaching. So whenever there is any increased activity, there is a more number of action potentials reaching the axon terminal, and as a result, there will be a release of more neurotransmitters, and there will be increased activity in the postsynaptic membrane. This is called potentiation. Okay, that is the increased activity of the synapse. The opposite of it is the depression. So whenever there is reduced activity or like no activity at all, there is minimum number of action potential reaching the axon. Okay. And as a response of it, there will be less number of neurotransmitters released into the synaptic cleft, and what happens is reduced response from the postsynaptic membrane. So these are the 2 types. Okay, I like you need to understand this so that like when I tell the principles of neuroplasticity, you will be able to correlate it. Okay. Then second one is the synaptogenesis. Okay, synaptogenesis is nothing but formation of new synapses. You can see there is something called as sprouting. Okay, that like you can see in the second picture. So whenever there is potentiation in the first neuron, okay, when there is like more number of action potentials are reaching, okay, there will be growth of new axonites from the axon, and from the the adjacent neuron, they will be developing new dendrites. Okay, this will be forming new synapses. This is called synaptogenesis. There is another activity called as synaptic pruning. Okay, this is nothing but the selective degeneration of the axons. This happens during the normal developmental process. So you can see at the like 36 weeks of gestation how the number of neurons are there in the first picture. Okay, then in the newborn how it is. Then 3 months it increases more. Then 6 months, okay, again it's more. And 2 years is something which is very crucial, where it reaches the maximum, the number of neuron connections. Afterwards, this synaptic pruning takes place. Okay, this is nothing. This is not a pathological process. This process takes place in the normal development process. Okay, so the brain itself does like it. Removes all the unwanted memories or unwanted kinds of membrane connections or the neuron connection. So this is one form of neuroplasticity which occurring in the development. Then it decreases and it goes till 6 years. Okay. Then there is something called the neurogenesis. See, when we were studying and all, like we were not aware of this neurogenesis and all. So even we were thinking that once the adult brain matured, there is no neurogenesis, and this neurogenesis is thought to occur only in the during the embryonic stage. Okay. And maybe till postnatally, to some extent, there will be formation of new nerve cells. But recent studies, we are able to find out that this neurogenesis takes place, okay, even in the adult brain, especially the dentate gyrus of the hippocampus. Okay, so we know that hippocampus is concerned with formation of new memories and all, okay, or learning new activities. So definitely we need new neurons for like making these kinds of memories or like learning these kinds of activities. Okay. And another thing is like once the neuron cells form, okay, it has to migrate to its position where it is needed, because the position determines the function of the neuron. Okay, so from the site of neuronal birth, it moves to the target cell. There are two kinds of migration. I'm not going to detail of it. One is the radial and another one is the tangential migration. So you can see that picture in that. One is the radial migration. You can see that pink color of neuron, how it is migrating. And this tangential, you can see how it migrates. Okay. So just keep it in mind, there are two kinds of neuronal migration. So why we need to again study these kinds of neuronal migration and all? See, because we believe that once we are able to learn more about these things, we will be able to treat successfully the patients with developmental disorders. So we know that like there are a lot of developmental disorders, and we have also like problems, neurological problems affecting the kids, cerebral palsy, autism, and all those things. So when we are able to like understand, we might be able to treat these kinds of problems to some extent. Then this is the neuronal cell death. Again, we need to see that there is three types of cell death occurring. One is seen in the developmental neuroplasticity, that is during the normal development. So it's something called as apoptosis, nothing but programmed cell death. Okay.
Vipin sir,
yeah, tell me.
Could you just make it a little more louder?
Louder. Okay. Am I audible now?
It's audible, but your voice.
Is it okay?
Yeah.
Is this okay?
Okay. Continue.
Yeah. Okay. Thank you. So next one is the neuronal cell death. So again, there are three types of neuron cell death happening, and we need to see. I'm not again going to the details of it, the biochemistry aspects of it. This can be very much boring. Okay. So type 1 is seen in the development. Okay, that is in the normal people during the development. That is the apoptosis or the programmed cell death. Okay. Then the second one is seen in the degenerative conditions, and the third one is seen in the inflammatory conditions. Degenerative conditions like Parkinson's diseases and all, Alzheimer's disease, and inflammatory conditions like multiple sclerosis. So again, why we need to know about these kinds of cell deaths and all? So again, if we are able to find out or like study in detail, okay, what are the process happening in these kinds of cell death, we might be even able to prevent this. Okay, prevent degenerative diseases, and also we will be able to cure the inflammatory diseases. So coming to the functional plasticity. Okay, so I told you that there are like two types of plasticity. One is the structural, what are the structures happening that we have seen, okay, the changes happening in the structure. Then next one is the functional plasticity. There are like four types. The first one is the homologous area adaptation. So now recent studies have proved that if you take for example a stroke patient and you have a middle cerebellar artery occlusion, ischemia, or hemorrhage that is resulting in the damage of some, for example, take some example of a speech area, for example. Okay, And what will happen? The corresponding portion in the opposite hemisphere. Suppose there is a damage in the left hemisphere, the right hemisphere, the corresponding area in the right hemisphere will take over that function. Okay, this is one kind of plasticity occurring. Okay, so again, the problem will be with this is that if the functions are taken over by the other area, what will happen? There will be crowding. Okay, there will be more number of functions this area has to do, and these kinds of patients will develop difficulty in performing dual tasking. Okay, so we know that like dual tasking is one kind of training we do for stroke patients or Parkinson's patients and all. Okay, so while walking, let them unbutton or button a shirt or count the coins, or these are kinds of dual tasking we give for patients. So they might have problem with these kinds of carrying out these kinds of skills. So another one is the cross-modal reassignment. This is nothing but occurs when structures previously devoted to processing particular kind of sensory input now accept input from a new sensory modality. So this how it is like to take an example, somebody like becoming blind, okay, loses his eye or something. Okay.
Sir, your voice is less.
Just a second. Let me adjust it. Just give me some time.
By the time we have Dr. Vinod Raj, Vice President of IEP Kerala, over to Vinod Raj to have a few words. By the time Vipin sir will adjust the sound.
Thank you, President, for the privilege. It's a real an honor to be to talk a few words on this wonderful platform, and most welcome to Dr. Vipinnath. It's really a privilege for IEP to have such a great faculty like you with us today. And so far, as always we said, the first began is best began, and the first impression you have given to us so far is really impressive. I'm sure that everyone over here will be having a very fantastic time over here with you, and a wonderful session also, because a new thing, the vulnerability of the brain is something many doesn't know, that the brain can be vulnerable. So let's see, wait for a wonderful session from you. I'm not taking much of your time, and thank you, Chairman, once again for the privilege. Thank you so much.
Thank you, sir. Thank you, Vinod, sir. Okay. Let's go back to the session. I think, am I audible now? I've adjusted my mic volume. Hope it solves the issue.
Yeah, it's okay now.
Okay now. Okay, thank you. So we will continue. This is something called as cross-modal reassignment. Okay, so suppose a person suddenly becomes blind. Okay, what will happen? His there will be increase in his auditory capacity and also his tactile sensitivity. So if he's learning this braille script and all. Okay, so this is what it will happen. The area of the eye or vision will go off, and there will be expansion in the tactile representation and also in the auditory representation. This is what kind of cross-modal reassignment plasticity will teach us. So that means that we can do some kind of compensatory strategies. Suppose a patient has to walk, we need to keep on giving some auditory command. We can give some visual cueing kind of thing. So this is what cueing does to our brain. So suppose we need, I think we all remember how we train for the Frankel's exercises and all. We'll be keeping like designs of the foot where the patient has to keep his leg and walk kind of thing. So these kinds of visual cues will be helpful in developing these kinds of cross-modal reassignment kind of plasticity. Then another one is the map expansion. So this is also very important. Suppose if we are keeping training one or learning one new skill and keep on improving it, this map will expand. That is like, suppose you can see here, suppose you are learning one activity and you are keeping on practicing it. You can see in the second picture, the area devoted has increased. Okay, so this is what the map expansion means. Suppose you are like practicing on something like manual therapy. I am very much fond of manual therapy, even though my specialty is neuro. See, you can develop a lot of palpatory skills, okay? And your representation of fingertips in the brain will become expanded. Okay, that's what the map expansion tells. So always there is a chance for training some function and which can be improved. Okay, that's what we need to look into it. So whenever we train a patient and the patient is able to do that function for some extent, there is always possibility of improvement. Okay, that's what this map expansion will teach us.
Sorry, sir, you need to have more volume.
Now, what about now?
It is audible, but
okay, this is the maximum I can do.
Talk loudly.
Like,
talk loudly. Okay.
Okay. Fine. Then another one is the last kind. Okay, that is the compensatory masquerade. Okay, that is nothing but the doing a same task in different ways. Suppose we know that, like, if we are walking, okay, many of us will not be walking the same. Or for example, I can tell that suppose from the college, okay, I need to go back to my home. Okay, and I have one minimum, that's the fastest route. And I also have other routes. Okay, suppose there is a damage in one route, or like one route is blocked because of some reason. Okay, I can always opt the other routes, which might be longer, but I will be able to go back to home. So that's kind of compensatory masquerade is like pointing us towards. Okay, so one way, if we are not able to do, we will be able to do functions in another way. Okay, so that's all the kinds of plasticity, different types of plasticity. So hope you are able to remember this. So with this, keeping these things in mind, we need to go into the final part of the topic. So before we get into the final part, that is the principles, there are some things we need to look into it. So the clinical picture of the neuroplasticity. First, we see how the plasticity, neuroplasticity affects us negatively. So there is age-related brain function. Okay. Suppose we all are aging and our brain functions start to decline. This is one kind of neuroplastic change which is happening. And there is altered motor control. It can be due to injury or any kind of things. Okay, so or something like non-use of it. Because recently my friend was telling, once the lockdown was released and everyone started going into the road using their vehicles, he was mentioning that I haven't seen any people driving so badly in the road. So around like 1 month or 2 months, people are not at all driving, and like immediately one day they are out with their vehicles and they are not able to drive very well as like they used to drive before. So these kinds of neuroplastic changes has taken place when they are not at all driving during that lockdown period. Okay. Another one is the impaired performance of activities of daily living. So even that can happen. Okay. So something which we don't do usually can we might develop some impairment in the activities of daily living. Okay. Then there is increased perception of pain. Okay, because of injury or like sensitivity, increased sensitivity of the nervous system. We know there are conditions like fibromyalgia and allodynia, complex regional pain syndrome. Okay, without any tissue damage or anything, the brain will be perceiving pain. Okay, so we know that pain is associated with some kind of tissue damage, but chronic pain, there might not be any kind of tissue damage, but there will be perception of pain in the patient. So sometimes we used to tell, no, see, it's all in the brain kind of thing, and the patient will feel very much depressed. So we need to put it properly, something like this is your increased perception of pain. Okay, so that's the reason. And there is something called as learned non-use. Learned non-use is nothing but if a patient develops stroke and he gets paralysis over his limbs. Okay, what will happen is that he will not try to use that limb, even if it is a mild weakness. Okay, because in order to hurry up or do complete a task, he won't be using his affected arm. For example, you can take we button and unbutton our shirts. Okay, with the use of two hands. Okay, suppose a person gets a stroke and his left hand is affected. In order to complete the task of buttoning and unbuttoning faster, he will not use his left hand. He will be using only his right hand and he'll be doing the task faster. So over a period of time, like since he is not using his affected limb, he starts developing something called as learned non-use. Okay, this can be very dangerous. Even I have seen in the OPD, our own students, okay, even though like I tell many times, okay, they keep on training the patient, functional task, everything. And finally, once they are out of the department, okay, when they give their OPD ticket to at the counter, they just give it back for entering. They'll be using their unaffected arm. So this is this is not fair. Okay, so if we are training the patient to use the affected limb, he should be keeping on trying to use that affected limb. So remember, okay, you need to motivate the patient to use their affected limb. Okay, when you train these kinds of patients, and we have something called as phantom limb sensation. You might have heard about it. Okay. And there is also a person called V.S. Ramachandran, who's from India. He's settled abroad and he has done a lot of studies in the phantom limb. You can read about it in the Wikipedia, and a lot of research articles are also about it. It's phantom limb. So you remember the picture which I put, and I was mentioning about Paul Broca. Okay, so Broca has localized all those areas, and we have a representation for the legs as well as the hands. Okay, so what will happen if in an accident or something, a limb is being removed? The patient's representation, the cortical representation in the brain will be still intact. That is not it's not removed. So what will happen? The patient will start having the sensation that the limb still persists there. Okay, this is called the phantom limb. This is due to the one aspect of plasticity. Okay, and the positive side. Okay, this is what which should motivate us. Okay, while treating the neurological patients. Okay. So we can learn new skills. Okay, but suppose today, if I don't know how to drive a car and I am very much fascinated in driving car, okay, I can go and learn that skill. Okay, so age might be another factor. I won't be like if I'm very much older, there will be some kind of difficulty I'll be facing. But in when we are young, we will be able to learn new skills very faster, and that too when we are fascinated or very much interested in learning a skill. Suppose I'm not good in maybe like badminton or something, and I want to learn. I have some friends who are always calling me, come, you join us, like that. So there is always chance for me to go and learn that new skill and continue that. Okay, this is the positive side of plasticity. And see, we can train for more communication between the sensory and motor pathways. So we give a lot of agility training in sports and all. That is like neuroplastic changes are very much important for agility. Okay, so this will be improved. Agility training will be improving or like helping take place some kind of neuroplastic changes. So we can even improve the function of aging brain. So like one of our students, they're doing some research on something called as the neurovics. Okay, so it's one area which has not been explored. Okay. So what will happen? Like we can train. Okay, suppose we can just tie something around our eyes. Okay, okay, and improve our auditory and tactile skills. Okay, even if we close our eyes, we might be able to move around in our own room, which is very familiar to us. We will be able to locate where the bed is, where the almirah is, or like where the switch is, all those things. Suppose like immediately, sometimes when current goes off, we will be able to uh, locate the switch, which we need to something like we need to disconnect, or like some inverter or something which we need to switch on. Okay, that can be done, or we will be able to reach for the candle or matchstick, whichever is like required. So this is possible, and these kinds of skills can be developed with training. Okay, then another one is the slowing down pathological process. So something we can take example of Parkinson's disease. Okay, so in case of early stages of Parkinson's disease, we can train the patient with some kind of regular exercises program, which can delay the progression of these diseases, which has been like proven with researchers. Okay. And there can be like, we can use strategies to improve or promote the recovery from sensory losses. We can improve the motor control with a specific kind of exercises, tasks, and we can even improve our memory. There are some exercises like which we can do to improve our memories. So all these things are possible because the brain is plastic. So hope you have a picture about the plasticity. Now we will go to the main portion of today's topic. Okay, that is the principles of experience dependent neuroplasticity. Okay. So the first principle, okay, there are 10 principles. The first principle is use it or lose it. You can see the picture here. That is, failure to drive specific brain functions can lead to functional degradation. So we are not that good in mathematics. Okay, that's why we are into this field of medicine and like medical field we are. Okay. So when I ask you some calculation, okay, 5 plus 6 plus 9 plus 19 plus 28 plus something like that. Okay, we won't be able to calculate it immediately. Okay, so if you ask the same question to somebody in the previous generation, maybe your father or like forefathers, I mean grandfather, someone is there, they might be able to tell it spontaneously because they might be good at it. Okay, since the like invention of this smartphone, yeah, like all these skills have like reduced in us. So that's why like we have some kind of, research and biostatistics comes together. That's why like we hesitate to, that's what I see. Many people hesitate to read research articles because we see some numbers, p-value 0.05 and all those things, which we don't really understand. I mean, okay, so that's what. So if we don't use it, we might lose it. Okay, so I've already given the example of learned non-use. So if we don't use our paretic limb, or if we don't make the patient make use of their paretic limb, they will lose the limb. I mean, they lose the functional capability of the limb automatically. So how this can be applied is we need to continue training. Okay, the patient is coming to you. You need to continue the training, improve the function, and he has to stay functionally independent. It's not like, okay, the patient says, I'm recovered, okay, let's stop physiotherapy. Don't do that. Okay, at least you tell that we'll have a like a revision or review, like some 2 weeks later or 1 month later, like that. Then you can do a reassessment with your outcome measures, whatever. Suppose you are using a work balance scale. When you wind up the session, okay, in a patient, okay, where you feel that he's good to go, okay, you take his balance measurement and you do an assessment 1 month later and see whether there is any problem or it's same, and let him continue the exercises. So that way we can make sure that he will be functionally independent. Whatever the skills we developed, putting our lot of hard work, that can be maintained. So that's what you use it or lose it says. So if we go to the second principle, that is the use it and improve it. Okay. So once we learn some skills, suppose we are learning some new skill, okay, riding a motorbike. You can see that like once initially we will be very much conscious. Okay, I need to press the clutch, I need to shift the gear and all those things. So in the road, we can see like a lot of people, I don't know how they are able to do that. They'll be keeping mobile in the one ear and they'll be riding the motorbike with only one hand. Okay, or like they'll be clamping the mobile with their shoulder and ear, and they'll be riding the motorbike and all. It's all very dangerous. But what I mean to say that we, with practice, we might have improved a lot in that particular activity. That's why we are able to do more challenging activities. Okay, so training that drives a specific brain function can lead to an enhancement of that function. So the skills acquired through the training should be put to daily life situation and improved. That's the application. You are training some sit to stand, okay, for a patient. From a bed, the patient is able to stand. Okay. Once the training is over and the patient gets up with like using his hand for support and getting up, don't make him do that. Okay, these kinds of activities you should make sure that he is incorporating with his activities in daily living at home. Okay, that's what the application of the second principle tells us. Okay, hope I'm clear about it. Then another thing is this is more important. This is called specificity. See, the picture itself is self-explanatory. You all know about Arnold Schwarzenegger. Okay, so if you need muscles like him, you need to train like him. See the kind of weights he is using. Okay, so the nature of the training experience dictates the nature of the plasticity. So if you want to, this is very similar to your SAID principles in exercise therapy. That is the SAID principle, SAID, specific, sorry, specific adaptations to imposed demands. Okay, so whenever a patient comes to you, you need to ask for the patient's chief complaint about his difficulty in doing functional activity. Suppose the patient is telling that he is having difficulty in writing. You need to take a pen and paper and make him hold a pen and make him write it. And you can use like some pre-training exercises, and you need to make him write, or otherwise he won't be learning writing at all. There is no point in training him in blackboard or any other things. That won't be helping him improve writing. Suppose if the patient wants to do some activity like opening or closing a door, you need to take the patient to that door and make him do that function. Okay, this is what the specificity teaches us. So always train for the specific function which the patient demands, and you need to train that particular function in that particular context. Okay, this is what specificity teaches us. So my question is, can strength training improve skilled activities of daily living? See, not at all. Okay, you can give some strength training that has a benefit of its own, but it won't be giving you any kind of functional outcome. See, even the kind of strength training or the resistance training, what I see is like, I don't mean that like you take a 1 kg of weight cuff and put him a tie around the wrist and make him do some flexion extension movements and expecting him to develop strength in daily activities. No, it's not like that. See, strength training or resistance training can improve the health of the muscle. Okay, you can have a lot of mitochondria develop and a lot of muscle plasticity changes can be developed. but that training won't be directly helping the learning or performing the activities of daily living. Another one is the repetition matters. This is also very much important because the induction of plasticity requires sufficient number of repetition. So acute stage should be seen with caution. So more number of repetitions will definitely make more number of, more plastic changes. But in the acute stage, like don't attempt more or don't allocate more time on treatment or like more repetitions, maximum 5 to 10 and maximum total 20 repetitions. That too, you can give it in 3 or 4 sets. The researchers show that if you need to develop a skill, there should be 2000 to 3000 repetitions of movement. Okay, and maximum of 300 repetitions can be done in an hour, or at least 100 repetitions for upper limb training in a day. So don't get moved with this, all these kinds of repetition numbers which I'm mentioning, because it's not brain itself is making the change. We have the muscles, we have the ligaments, joints. Okay, so if you don't choose your repetitions properly, you can develop soreness, you can develop swelling in the joint and all those things, complications. So always check the capacity of the patient. If you are going for resistance training, okay, always check the repetition maximum, and maximum number of repetitions should be 30 repetitions for exercises. That too, you should give it in 3 sets. Okay, and you need to keep on increasing the resistance, or otherwise there won't be any kind of improvement in the muscle strength. Okay. So always remember to use optimum number of repetitions. Muscles and other tissues should not get injured, okay, due to increased repetitions. So these are just result. This 2000 and 3000 are like results of some studies done in the animals. This can be applicable in case of normal people, or you feel that the patient is
Hello, sir.
Hello, Vipin sir.
Vipin sir, are you there?
like his overall health and everything is good. But I feel that, okay,
Sir,
people,
last few seconds, your voice is not audible. Can you please?
yeah, sure.
There was some disturbance in internet.
Yeah.
And maximum louder. Even you need to be a bit more louder. It is audible, but
because I don't know what is the problem. Till yesterday I was using this Zoom, and like, is it okay now? Because I don't have any other options. That's
okay, go ahead.
So
Problem, sir. I think it's the internet problem is there.
Yeah.
Okay. Yeah. Okay, sir. No problem.
So what I mean to say is that this skill development, which I was mentioning, 2000 and 3000 repetitions and all, these were done in animal models, and we were able to see how much repetitions is needed to develop a new skill. So that doesn't mean that like we need to give 2000 or 3000 repetitions to a patient directly. We need to take into account of his overall health, and always try to do maximum number of repetitions, whichever is possible. So if it is like 50 to 60 is the maximum, we need to stop and see to that he's not developing any soreness or anything the other day. Okay, so that's how you need to go about the repetitions. Okay, hope that makes it clear. And the next one is the intensity matters. So induction of plasticity requires sufficient training intensity. This is one very important thing. So we don't usually do it. We need to do a gait training to a patient. we don't actually do it technically. What I mean to say is that I don't know about the others, but here most of the cases where I have seen, they don't even check the patient's aerobic capacity. We have scales like Bogg's rating of perceived exertion and all. Okay, so we need to use those kinds of outcome measures and find out the patient's exercise capacity, and we need to give to that capacity. Then only we will be able to tell that we have made some changes in like some days of treatment. Okay, then definitely the capacity also will be improving, and we can increase the intensity. Okay, that way it should be. So what I mean to say is that uh, the more intensity, the more and the long term. Okay, the plastic changes also will be more. So you can go through this link. There is a website called neuropt.org. If you or simply if you type the intensity matters in Google, you will be able to go to this link where you can see how like we can give locomotor training for neurological patients more in a scientific manner. Okay, see, we need to keep on improving our skills. Okay, so if we are doing this, we are measuring patients' heart rate, BP, and all before exercise, and like we are training them, the patient, and immediately after, again we are measuring that. I don't know how many of you do that, because this will always, improve our like the way they perceive us, the patient they perceive us will be going to improve. Okay, so always try to do this in your clinical practice. Whoever are clinicians, okay, just go to this site and learn about download these resources. They have like telling how to measure the maximum heart rate and also how to measure the heart rate reserve. So always take it into account that patients like stroke patients, they'll be having cardiac complications also. Okay, so take it into account of the patient's exercise capacity and decide the intensity. And look beyond the nervous system. Okay, suppose you want to give locomotor training, the patient might have some kind of ONE or any other thing, any problem in their lower limb. There can be muscular weakness and all those things. So those things has to be addressed along with it. Okay. Then the sixth point. Okay, this is like more of biochemical aspects into it. So I'm not going to detail of it. Okay, one thing is like you can see the clock here. So in our daily life, okay, we have some kind of routine. So we get up at somewhere around 6:30 or 7. Okay, since it is a Sunday, like okay, might also get delayed. But in weekdays, okay, we can have something like breakfast at 9 o'clock. Okay, and something like lunch at 1 o'clock, and all those kinds of things, or like going to work out at a certain time and sleep time at 9:30 or 10 kind of thing. So we have certain kinds of activities we do at certain times. Similarly, plasticity also occurs at different times during training. For example, I've already mentioned that there will be neurogenesis, and I've already mentioned that there will be neuronal migration, and also I have also mentioned that there will be neuronal cell death, which is taking place. So all these things will be taking place at particular time for a particular neuron. So different forms of plasticity occur at different times during training. So here one thing is, when we give a motor skill training, there can be changes in the gene expression, okay, which will be preceding the synapse formation. So there was a study which I have quoted here. They have given some 5 weeks of rehabilitation program for stroke patients, and it was given. First group was given the rehabilitation process started at 30 days after the infarct. The another group, which was started 5 days. That is like only 5 days after the stroke has happened, they have started the rehabilitation program. So the people in the group which started 5 days post-stroke, they showed more improvement than the people whom we started with after 30 days of stroke. Hope it is clear. This means that the earlier, the better. And also one more thing you need to be cautious is that I don't mean to say that like when the patient is in acute stroke, we are supposed to train him to the maximum. It's not at all like that. We need to wait at least some days. That is like at least 5 days till the physician tells you can go about the rehabilitation. You can start with the rehabilitation. We can start like with very simple exercises and all during the acute stage, and see to that it's not prolonging. Okay, so that way the intensity has to be chosen with the time. So always remember, the earlier, the better. And this is the seventh principle. This is a very, very important thing. Okay. This is a very, very important principle which you need to take it into account when you treat any kind of patients. The training experience must be sufficiently salient to induce plasticity. That means that the kind of activity you choose, that should be very much important for the patient. Suppose a patient is coming to you and telling that I live in the first floor and I need to, or I find difficulty in climbing stairs. What you need to do, you need to take the patient to the stairs and analyze why he is finding difficulty in climbing stairs. There is weakness, okay, you train it. Okay. There is any difficulty with the initiation of movement, you put him in some active assisted exercises. See, this is the way you need to train. Suppose, like I've already mentioned, if the patient is coming to you and telling that I am a teacher and I need to write on the blackboard. So depending upon your assessment and things, you need to start with that particular activity. Or if it's very severe and where you need to, you cannot do it that way, you need to find out some alternative ways so that the patient can perform the activity. If you go for the previous example of climbing stairs, you can ask the patient to like do some modification. If they don't have any handrails at their home, you can ask the patient to fix a handrail so that he can hold it and climb it easier. Okay, so this is what salience matters. Okay, and motivation and attention are another thing. Okay. Suppose if a patient coming to you telling that I'm having difficulty in like drinking water and all, so you don't simply train them for your pegboard reaching and all. Okay, you ask the patient to hold a steel glass. Okay, and what you need to do is you take some water, put it in some kind of small polythene bag. Okay, fill water and okay, seal it and put it in that glass. So the patient will have that feeling of real life. Okay, that real experience of holding a glass. Okay, and you can ask the patient to do the task and analyze, and you can go about it. And once the patient is able to do the activity or not able to do the activity, you need to keep on giving a positive feedback. Don't give a negative feedback. Okay? You can tell something like a good try. You have done a very good try, and you can give some reward points. Something like out of 10. Today you can today you have scored 7 out of 10, or today you are able to score 6. Yesterday your score was only 5, but you are able to do this much and you are improving. Kind of feedbacks, if you keep on giving the patient, definitely the patient will be improving. That's what I mean by the term salience. Okay, so this is a very, very important concept of neuroplasticity. You need to remember whenever you train a patient, because it will be easier for the patient to learn the activity which he is interested to do. Then another thing is the age. Okay. The effects of brain damage may vary with developmental age. And remember, it's very difficult to train very young as well as very old patients, because very young patients you won't be able to instruct in a proper way, and very old people might not respond. Okay? The plastic changes might not be as like in younger people. So always take it into account of the person's age also. Okay. And if the patient is more than 80 or 90, and like don't attempt like very severe kind of things when you treat. Okay, just see to that whether he will be able to roll over the bed, or like do some get up and do some lying to sitting, or some kind of sit to stand. Those kinds of minimal activity you can attempt, rather than like making him climb upstairs or any kind of thing. Okay, so always take it into account of the patient's age, because very young and very old people will be difficult to train. And in the middle, whichever like comes, okay, the younger the age, okay, the plastic changes can be easy. So the ninth principle is transference. Okay. So transference, you can see this picture here. So there is a picture of a bicycle here, if you can see above, and there is a picture of scooter. So how many of you had difficulty from shifting from bicycle to riding a scooter? I think you might not have much difficulty. Might be if boys who try to learn bicycle and shift to some motorbike, they might have faced some difficulty due to shifting gears and the use of clutch and all those things. So this is what, okay, transference means. Plasticity in response to one training experience can enhance the acquisition of similar behaviors. What I mean to say with this principle is that we do a lot of training in the clinic, okay? Focus on training functions, okay? These has to be transferred into the activities of daily living. You are training sit to stand, the patient has to practice it at home also, sit to stand. It's not like they have to get hold of something and get up kind of thing. These kinds of things you should be careful. Okay. So this is what I mean by transference. Suppose if a patient is telling like, okay, is finding difficulty in like sitting down on the floor, you need to train that way. Okay, and you can train from here, okay, in the OPD, like squatting down, which he can use it at home for going to the toilet. So this way the training should go. And we have reached the last principle of neuroplasticity, that is the interference. Okay. It's nothing but something is interfering with, okay, or disturbing. So sometimes these plastic changes can be disturbing also. The plasticity in response to one experience can interfere with the acquisition of other behaviors. So again, the example is the learned non-use. So these kinds of things can like definitely affect, okay, our training. So these kinds of negative effects of plasticity. So another example is that the patients after stroke, they tend to use a circumdactory gait pattern. So if you want to the patient not to walk in that circumdactory pattern, okay, you need to facilitate that normal hip flexion, knee flexion, and ankle dorsiflexion. Okay. Meanwhile, you need to put the patient near a wall or something. Okay, the affected side comes near the wall, or some kind of constraint you can put there, so that when he takes his step forward, he's like having problem with that, and he's tempted to use more of hip and knee flexion. So these kinds of interference also has to be taken care of. Always remember, prevent compensatory movements that are not at all useful or which interfere with the. So with this, like we have come to the end of the session. I think we're almost there. It's going to be 12 o'clock. So if you have any doubts, can be typed in the chat box.
Thank you,
Okay,
sir.
I'll hand over to Srijit, sir. Yeah, tell me, sir. So before that, I'll just put this slide. This is the summing up. If I can, if you can give me 1 more minute, like I'll sum it up so that they have something for taking home, some take-home message.
Yes.
To sum up, continue the training to stay functionally independent. That is, use it or lose it. The skill acquired through training should be put into daily life situations and improve it. That is the use it and improve it. Then the third thing is the train for the specific function. That is the specificity. Then fourth one is the optimum number of repetition. That is, repetition matters. The fifth one is the training program should be according to the patient's capability. That means intensity matters. Okay, and start the training at the earliest. Okay, that is the timing matters. The function which is important to the patient is easily learned. That shows that salience matters. And always remember to motivate the patient and give a positive feedback, or reward points also can be given. Then training-induced plasticity occurs more readily in younger brains. So age matters. Okay. In clinic, focus on training functions that can be transferred as ADLs at home. Okay, and prevent compensatory movements and behaviors that are not useful. That is the interference. Okay, thank you, sir. I'm handing over to you. We'll have the question and answer session.
Thank you for the wonderful session.
Okay, okay.
We daily used to come over, but
okay.
You have put it all in a codified matter.
Okay.
So that we can correct our mistakes. See, we have some other questions from the audience. Shall I continue with the questions?
Yeah, yes, sir. Yes, sir.
It's a question. Is there any way so that we can speed up good kind of plasticity changes in brain?
Speed up the plastic changes. Okay, fine. See, the plasticity is a natural process, just like healing, it takes place. Okay, but there are some studies. Okay, there are some studies showing that if we continuously keep on challenging our brain, we will improve plasticity. Okay, that is like there are secretion of the happy hormone serotonin, and also like something known as the brain-derived neurotropic factor. Okay, this all helps in improving the plasticity. Even though there are like a lot of medications, see these kinds of hormones when released from our body. Okay, this is more helpful than taking medication. So exercises, resisted as well as aerobic exercises, which are always progressed. Okay, this can improve some plastic changes. Sir, is that clear? Sir, that makes it right.
I think it is clear.
Yeah. Yes, sir. Tell me.
Another question: what is the danger of doing more number of repetitions in acute sense? Sometimes the patient is willing to do more exercises and will be more active. In that case, if you are doing more, what will be the effect?
Okay, yes, sir. In acute stage, sir, we need to remember, like, suppose we have an injury in the leg or anything. So we know that there will be inflammatory process and all going on. Okay. Similarly, there will be these kinds of inflammatory process within our brain also. Okay, and like we need to give time for the brain to heal to some extent. At that time, we should not keep on stressing, because we have one study which has been done on with the constraint induced movement therapy. Very acute patient has been trained with constraint induced movement therapy, and the results were very deteriorating. Okay, like it's not that rewarding. So at least we will wait for some days to start some intensified program. But before that, we can do things like very simple exercises. And one more thing is that, like, if we keep on doing more repetitions, we know that, like, I've already showed that picture of cortical representation. See, this can expand, and it will expand at the expenditure of the other portions. Okay, suppose we are training the leg function, and it might be like even at the expenditure of the portions which have been allocated for the arm. So later it will be very difficult to train the arm if we train more like in the leg. Sir, is that okay, sir?
Yes, sir.
Yeah,
As I said,
okay.
when a patient, normally in our situation, when the patient is discharged, they'll be going home and doing something, and they will be adapting something. If a patient comes with a chronic stroke with a maximum adaptation, is there any role for this?
So which one, sir? Like plasticity?
Yeah.
Chronic patients also, like definitely the plasticity will occur, but the chronic patients, what will happen? There will be a lot of biochemical changes happening in their muscles due to spasticity, which will be again difficult and which can interpret with the our improvement. So these kinds of things has to be taken care of. Okay, acute stage, okay, we can see that there is less chance of all the other changes taking place. But chronic stage already things have been like more of kind of fixed, and we might like find some difficulty. It won't be that easier as we train the patients in the acute stage.
Okay.
Yeah.
One more question. Is this neuroplasticity applicable in musculoskeletal conditions?
Musculoskeletal in the sense mainly movement and pain and your rehab kind of thing. So whatever, like whether it's movement or pain, brain is the one thing which is controlling. Okay, and we have this conditions. Suppose if it is an acute pain, okay, the brain is giving signal that don't move, the injury can worsen. Okay, so we need to find out that because of the injury. But in case of chronic cases, there won't be any kind of tissue damage. The brain can be seen as sensitized to that injury or anything. So definitely there is no harm in moving because there is no injury in case of chronic conditions. So the sensitivity of the brain has been increased. That way the plasticity changes has taken place. And we need to see in that aspect and we can train the patient. Okay, in chronic condition, there is no tissue damage. So that's the difference. And this is one thing which musculoskeletal people, they need to understand. See, whatever the injury, you have muscle injury, joint injury, or we have different kinds of ligament injuries and all. We will be able to do a differential diagnosis. So whatever the injury is, the pain is produced by the brain. It's not the tissue as such is causing the pain. Okay, so this is like pain itself is a vast topic, and there is something called as neuromatrix theory of the brain. Okay, which like if you can refer, I don't know who has asked that doubt. I recommend them to refer the neuromatrix theory of the brain and also the biopsychosocial approach to pain. Okay, by David Butler and Dr. Lorimer Mosley. They give a lot of things for the musculoskeletal people for the understanding pain. And also there is a book called Explain Pain, which can be read.
Okay, so that
Yes,
you're telling that there is a relation between pain and neuroplasticity.
Yes, sir, definitely.
Okay. And we have a lot of neurological treatment techniques. Which one, as per your opinion, which one will be the best for the regarding neuroplasticity?
Sir, like we know that there are like a lot of treatment techniques. If we ask someone, they'll be telling that I am like follower of some Bobard technique. I follow Brimstone. I follow task-oriented approach, or like whatever. Like there are a lot of things, and we have also electrical stimulation. And some people even do this passive movements, all those things. Passive treatments will not help in inducing plasticity. Okay, it's active movement or the active participation of the patient that only will be inducing plastic changes. Okay, and even there are studies showing that functional electrical stimulation and all those things. Okay, so functional electrical stimulation will help the patient to perform the function, do better, but the relearning of the task is not seen with the use of functional electrical stimulation. And another thing is that whichever treatment you use, okay, make sure that the patient is an active participant of that treatment, and the treatment technique focuses on accomplishing some goal, because we move for a purpose. Okay, because if I am thirsty, I need to reach for a cup of water and I drink it. If I'm not thirsty, I won't be doing that. If I'm like, once the class is over, I'll get up and go home. So why? Because I need to go home, and it's, I think, almost getting like a time for lunch. So unless until there is a purpose, we won't be moving. So make sure whatever treatment you do, make sure that the patient is an active participant. Okay, that's also.
You mean
I don't recommend any specific treatment telling that this is good or that is good. Whatever treatments are there related to task-oriented approach will be good, because there will be active participation of the patient.
You mean task-oriented training is better than having passive movements?
Neurophysiological approaches, but there are some condition. Okay, I say, like, suppose the patient is very weak, okay, and not even able to roll. Okay, what kind of task-oriented training we can give? We can we can't do some high functions. Only function things what we can make the patient do is to roll over, and something like we can give some target. We can keep some mobile. Can you try to roll over and reach for your mobile in the bed or something like that? That kind of task-oriented we will be able to give in when there is very much weakness. So I don't know, we can try for whatever facilitatory technique or things which are needed there to facilitate movements. So that way it should be like.
And how long it will take to get the neural plastic changes?
Sir, I told you, sir, this is a natural process, just like healing process. This neuroplastic changes take place one by one. That is one. There will be neurogenesis, there will be neuronal migration, and like a lot of things. So this takes its own time. But if we look at the picture of something functionally, we might learn some new skills within fraction of seconds. Okay, and sometimes we might take longer than months or something to learn some task or some skill properly. So it varies, and the patient's interest in that particular activity, learning that particular activity, the patient's motivation, okay, all those things, their support provided by the caregivers, family, everything matters. So that only will make the patient's plastic changes more. And it can vary from any milliseconds to months or days, depending upon the complexity of the task which is being trained for.
What about the cerebral palsy?
Sir, I told you, so it's a developmental condition. And so if we are able to train more kind of neuroplastic changes. That is a neurogenesis and neuronal migration and all. Okay, and it's very difficult, sir. Training these kids for some kind of specific function, because the kids, they are in a stage of exploring and learning things. So we can't train for some specific function. Okay, you are some 2 years of age, you should now walk or run kind of. Suddenly we cannot train. So we need to use some strategies. Okay, that neurodevelopmental therapy is something which still people use. So we can use that and see to that the kids are actively participant of that training, because I can still see a lot of people keep on stretching. Hello. Keep on stretching the tight muscles, spastic muscles and all. So instead of that, we need to facilitate some movements that will be functional movements, which will be helpful.
Sir, can I stop your screen sharing? Is it okay with you?
Yeah, sure.
Okay, sir. Thank you.
Okay.
Any role in genital disorders?
Congenital?
Genetic disorders.
Genetic, Duchenne muscular dystrophy you are talking? Yes, sir. So in case of muscular dystrophy, if we take, there is a problem with it's a genetic defect and the muscles are affected. So we can, what I feel is that we need to do treatments or do some target our treatments for improving the health of the muscle. Okay, so suppose this aerobic strengthening or resistance training, whichever is possible. Okay, that again, like we need to find out how much kind of the ability of the kid is. Then we need to train, because whatever we do, unless until we manipulate that genetical thing, it's a programmed one. The cells of the muscles will definitely go for that. See, there is some research is going on in the stem cells, that the stem cells are injected into the motor point of the muscles of the kid. And see, if you look at it, once the stem cells is being injected, the kids are put on exercise training so that the muscles will develop. So exercises and like are the one thing which we need to see with what extent the patient can do, then we can keep on training. Genetic thing, we don't think we'll get some permanent kind of result of anything, because the problem is already pre-programmed.
Yes, sir. Right now,
Yes, sir.
we have Dr. Fayaz Rahman, who has done PhD from Srijitra Institute of Medical Sciences, Trivandrum, working in Saudi Arabia. I welcome Dr. Fayaz Rahman Khan to have a few words.
Thank you.
Yeah, thank you, Sid sir, and the whole IIP office bearers to invite me in this platform. And I appreciate the efforts of IIP to conduct such workshops and webinars in this critical time. And I thank Dr. Vipinnath for giving such a wonderful and excellent talk on neuroplasticity. In fact, this is a wonderful talk, topic, because
I'm overwhelmed. Okay. I'm overwhelmed because of your presence, sir. This is like, okay, yeah.
And that's topic, this neuroplasticity is very difficult to understand, but you have made more simple for all the physical therapists and the clinical applications as well. So I appreciate you and all the best for your future. And I thank and I hope that IAP can conduct such webinars, which is more useful for the physical therapist and more advanced webinars like this. Thank you, the whole IAP team, for inviting me.
Yes, sir.
Can I thank you, because my thanking session was actually I kept it for last. And first of all, I would like to thank the IAP, our main IAP, and also the Kerala chapter, Srijit sir and Jim sir and Baiju sir, and from Kannur chapter, Riaz, he was the one who approached me, telling that, sir, you have to do something. You need to do something, at least for IAP kind of thing. You do at least do some presentation kind of thing. Then, I was not able to, disagree. I had to agree with him. And Biju sir and Subish, okay, everyone was motivating me to do this presentation. And also, I would like to thank my teachers, especially Vasandan sir, who has guided me in the some kind of clarification which I faced some problems. Okay, and also I thank my the students and patients, and also the staff and the management of Alvas College of Physiotherapy. Thank you all. If I left someone I don't know, or maybe also I have to thank my family, my wife and my parents also for cooperating with me. Okay, thank you all. Thank you for listening. Thank you all the participants for listening. Thank you.
And then we'll sum up. See, he was giving an informative lecture regarding neuroplasticity. See, we are coming across with many of the stroke patients, or many of the neurological patients with the maximum adaptations and circumdictory gait and shoulder problems and all. These are the contributions which we are giving to their brain. So we have to be more opt and active in the rehabilitation and regarding attaining the neuroplasticity. As he said, brain is capable of adjusting to whatever input we are giving. So we have to have a proper learning for the rehabilitation of neurological patients, so that we won't induce any wrong this thing to movement patterns or thing to the brain. Okay, we'll sum up. Thank you. Thank you, Vipin sir, Fayaz Rahman, my friend. Thank you, Vashini ma'am, and all other participants, and especially a special thanks to Alopi madam, who was behind the technical part and very cooperative, and without creating any problem, she has controlled everything. Thank you all. We'll sum up. Okay, we'll stop the. We'll conclude the session.
Yes, yes.
Thank you, sir. Thank you.
Thank you all. Thank you for patiently listening. Thank you.
Hi, Sir. Hello.
I can hear.
Sir, because this today's program actually it was very wonderful and nice, and only problem some voice disturbances were the only problem we have faced. But otherwise it was a wonderful session. But in this occasion we have to thank you already give them the thanking, but I have to say about our our secretary and treasurer, Dr. Riaz and Dr. Subish. They were behind in this webinar. Actually, we have to give them special thanks on behalf of the IEP and all our members. So I am using this occasion to thank them, and thank to all, especially our first Sri Sir and all the panelists and central treasurer also. Okay.
Thank you.
And Fayaz can, sir. Fayaz can. Sir, I yes, so you okay. Thank you too also for the nice words about our Vipinnath, sir.
Okay. Thank you.
Thank you. Bye.
Thank you.